So I thought before we actually get started with the agenda, I want to make sure everybody in the room understands a little bit about how supply chain is usually organized and in your world and in your role, what clinical integration means. So can you tell us a little bit about your role?
Oh, sure. So currently, in traditional form in supply chain within healthcare, there's something called value analysis. And that's really when we look at pricing and market share and contracting to look to see how we can standardize and utilize those things in a different way to save money. When we merged together, it was an opportunity to kind of transform what we were doing. So we opted to change and do clinical integration. So what that does is that takes the quality piece, the patient care. We look at all of those quality indicators. That's the leading discussions that we have. We then overlay that on top of the RFP or pricing piece of that, and then we make a united decision together as clinicians, physicians, quality teams, et cetera. So it's really a different approach than just value analysis, and it's something we're new at doing, but we are doing it for sure.
Pretty forward-thinking way to look at things and do things. That's really helpful. So we have a lot to cover today, and just to kind of orient you to our plan, we wanted to start off by just orienting you to Secours and Mercy, both to give some context as to what initiated or led to the merger between Secours and Mercy Health, and then talk a little bit about what the organization looks like today. And then we're going to dig into supply chain. It's an area that is oftentimes a huge focus and a rationale for a merger, but oftentimes the results actually don't pan out the way health systems expect them to. And so we're going to dig into some of the challenges that organizations face when they are bringing together multiple health systems, multiple data sets, et cetera. And then we're going to talk a little bit about how Secours and Mercy solved that problem and was able to see some really impressive results. We're going to talk about things both at a high level in terms of the governance and the infrastructure the organization had to put in place, but also some really tactical things that they've found to be effective. And then we'll wrap up by summarizing some of the key lessons here. We really want this to be an interactive session. It's still a small group, so feel free to ask questions along the way. And we hope you find it productive. So, to summarize, we want you to walk out of here today really understanding what it takes to make a merger successful when it comes to leveraging newfound scale in the supply chain, right? You bring together two organizations, you've increased your purchasing power, but what does it really take to be successful in realizing savings? So we'll talk about not just the analytics that you have to bring together from different data sets within the healthcare ecosystem, but other data that is valuable in aligning physicians, because you're not just bringing together two sets of data systems, you're actually bringing together a broader range of physicians who each have a preference to the products they use. How do you bring them all on the same page? And so we'll talk about both the technical work that has to happen, but also more of the governance work as well. To kick things off, we wanted to ask you guys all some questions just to help us understand kind of your pain points and what you've experienced. So we're going to launch a poll here, and we want to get a sense of, in the last 12 months, has your organization announced, engaged, or wrapped up a merger with another health system? Give you guys a second here to answer. All right, let's see the results. Not surprising, so nearly half of you, well, we knew this would happen. So about, half of you have been involved in a merger. If we extend out the timeline, like the last 2 years, I'm sure we'll see the numbers even go up further. Consolidation in healthcare is not surprising. So it sounds like you will all have some very relevant experiences to share with us and to contribute to this conversation. Next question. If your organization has had M&A activity, and this doesn't have to be in the last year, but over the last few years, how well would you say your analytics were used to expedite the goals and objectives of the merger? Would you say they were not used at all? They were not used well? They were used moderately well, very well, or you're unsure? Hopefully you're not unsure. So I'll give you a second here to answer. Let's take a look at the results. They were used moderately well, for the most part. But still, I mean, a quarter of you would say not used well. So interesting to kind of hear from you all as the conversation progresses, what you feel were your big stumbling blocks and pain points. Thanks for, oh, we got one more. On a scale of 1 to 5, how would you rate your organization's preparedness for future M&A? So if you had a deal announced tomorrow, how well set up do you think you are? Let's see the results. Interesting. So I think very few people would say that they feel really, really prepared. I think about 60% or so are in the neutral or neutral to not ready buckets. And I don't think that's surprising. I think a lot of times it's something that catches you off guard and you're not prepared for it. You're kind of focused on the day-to-day objectives. So I'm not surprised at all by your answers here. Thank you for contributing and for weighing in. I want to talk a little bit about the promise of supply chain synergy and cost reduction that healthcare executives, hospital executives usually have when they enter a merger, and then the reality of kind of the shortcomings of that. So what we're sharing with you here are statistics from a study that 3 professors from Wharton did, looking at data from 2009 to 2015. From health systems that had recently merged, and they wanted to understand what real benefit was there to supply costs. The aspiration, what they heard from executives was, hey, we were expecting to see about 15% cost savings in the 47 largest supply categories that a health system would buy. In reality, the results showed that the actual savings were about just 1.5%. So a tenfold gap between the expectations and the reality. And so obviously if you're looking at these statistics and anytime you think about getting into a merger, you want to make sure, hey, how do we not fall short? What's even more interesting is if you actually dig into that 1.5%, the acquiring hospital usually actually ends up spending more on supplies than it did before. And when you actually break up clinically sensitive spend categories versus commodity categories, the savings tend to accrue in the commodity categories and not in the clinically sensitive categories. And potentially the reason for that is because as a health system grows, and we're going to talk about that experience at Secours and Mercy, as a health system gets bigger, aligning your physicians becomes even more difficult. It's something we see at Lumere with our analytics and data. Oftentimes actually the smaller health systems get the best price. You would think, hey, the folks that actually are buying the most volume get a better price. That's not always true. And it's because aligning physicians is a really tricky challenge. And we'll talk about how to overcome that. So just wanted to kind of lay the groundwork around the main problem that we're excited to hear from Secours and Mercy about how they've gone, how they actually have done very well. And we'll share with you later the statistics and the impact they've had. But before we do that, Amy, can you just give us a little bit of background around the merger? What brought the 2 health systems together, just to get everybody on the same page?
Sure. So it was formally announced to all of the employees back in February of 2018 is when we were made aware that we were going to be merging. So it was not an acquisition, it was the merging of 2 like facilities. And the go live date for that was going to be September 1st, 2018. So that decision was based off of both finances and mission, goals, values. We were aligned with all of that. So that was when the decision was made. I'm sure they worked on it much longer ahead than when it was formally announced to us. And so that's the decisions why.
That was the impetus.
Yes.
And also two Catholic organizations,
Yes.
right? So there was a lot of, a big part of the reason here was more kind of the shared values.
Yes, yes. We were both doing well financially. Really, it was to come together to serve more. But there was neither one of us were in a financial.
And tell us a little bit about what the health system looks like today.
Sure. So combined right now, we have 48 hospitals. We have 43 on the state side. We have 5 over in Ireland. We have just below $9 billion in revenue. We have about 60,000 employees. We have over 2,000 physicians, 450 consultants, and in Ireland, consultants are physicians. So, so we have a pretty large organization as far as that goes. Yeah.
Huge geographic footprint.
Yes.
And there wasn't a whole lot of overlap geographically.
There was not. We did not have hospitals or facilities in the same locations.
Yep.
Correct.
So obviously that you now have just expanded significantly your footprint, and as you think about how do you actually work with doctors that you don't know,
Right.
and try to get them on board, we'll talk about that in this conversation, I'm sure. Tell us a little bit about the goals that you had in supply chain and some of the challenges you faced early on and as you thought about one organization.
Right. So shortly after we were told that we were merging together, we were given the mantra in supply chain that we needed to come together and figure out what our savings targets would be. Of course, there was a little bit of an issue, and we'll get into some details around that, but as being two separate organizations, there are laws around sharing, pricing, et cetera. So we were not able to get down into the nitty-gritty type of level. So we did look at some data at a high level to try to help us organize savings. We had a steering committee, and that committee still exists today, of our executives coming together, looking at everything, and they're the ones who landed on our savings targets. So,
and the savings target ended up being about 10% savings for supply chain, for kind of supply chain costs.
Yes.
And who's on your executive committee?
So our CFO, our CEO, our COO, CMO, and CNO. Yes.
So part of the challenge you had was obviously from an IT standpoint, but as you thought about how you would achieve your goals, how you'd get that 10% savings, you thought more broadly about the things you'd have to be putting in place, kind of the pillars to your success. Can you talk about those pillars?
Sure. So we knew that we were going to have processes put in place in order to reach any type of goal together. So we really focused a lot of the work, while we did have some data analytics that were happening behind the scenes, and we'll talk through that, but we really focused a lot, I focused a lot on the processes and how we were going to align as far as communicating, making sure we were all doing the same thing and working towards the same goal. So we spent a lot of time looking at that so that starting on September 1, we could really go instead of planning. So we planned before so that we could go on day 1.
So talk through some of the kind of the big process decisions you had to make.
So we were not able to make any type of decisions about staffing. Okay. So that was one that HR had said that we will not be addressing anything until after the merger took place in that. But we had to look at technology. So obviously we were using some different types of technology that presented a barrier for us. We have 2 different ERP systems. We still do today. We had to try to figure out, if you will, somehow to translate the data into one for us. So that was one of the things that we looked at. From a clinical integration perspective, we were blessed. We both used Lumere, very different capacities, but we did both use Lumere, so that was a more easy choice and decision. But we had to talk through a lot of that prior to even making the plan so that we knew what tools we had in place and what tools we needed in order to be successful.
And fundamentally, I'm thinking also some other process decisions you had to make. Do you make decisions at a facility level? Do you make it at a market level? Do you make it system-wide? How did you think through those decisions?
So everything that we're doing in the strategic side of supply chain is all at a corporate level. So everything that I'm focused on is at a corporate level, but we have teams in place that then get it down to the facility level. So everything that we're focused on is we do contracting and clinical integration all at the corporate level. Those decisions are made and then implemented and turned on in the facilities.
And you mentioned, the way that when you and I talked about this before, the way you worked with your physicians was different than the way Legacy Mercy worked with their physicians. Can you give some insight into that, and then how you thought about bringing them to kind of
so
one
culturally
approach?
we did have a little bit of some differences prior to the merger. So Legacy Bon Secours was a little bit more stagnant or stable with their executive leadership team. The Legacy Mercy team had just gone through a total flip of their executive team over the past 3 years. They had flipped, and they had a lot of savings and a lot of very large goals to go after as a result of that. In Legacy Bon Secours, we spoke more with the physicians. We got more buy-in. We considered all of that prior to making decisions. In the recent years in Legacy Mercy, they were more touch point of 1 or 2 key people and then making decisions and flipping them. So it was less interdisciplinary, more supply chain made the decisions with input. And I knew that from a long-term perspective, as far as being able to not just make decisions, but then live those decisions, I knew that we needed to have more of a collaborative, interdisciplinary approach. Yeah.
You mentioned kind of identifying standard technology solutions that worked across the big organization were important to you. Obviously, we were very excited to have had relationships with both Bon Secours and Mercy. And just talk me through kind of how you thought about the importance of technology fitting into your goals in general.
Right. So in supply chain, for sure, we believe in data, and we have a lot of it. And so we knew that we had to have source of truth, and we had to decide on those source of truth in order for us to be successful. So we had to make sure that everybody who had accountability to the goal, the savings goal, or the implementation, the processes, that we were all aligned in understanding the tools that we were selecting, and that we understood that as a way forward. Does that make sense?
Yeah. And just to give folks some context, if you don't know Lumere, at Bon Secours and Mercy, we were focused on helping through kind of 2 different types of workflows in supply chain. One was around the introduction of new products, to have one standard way of capturing requests from physicians and diligencing those requests and supporting committee level decisions. And then the other part is identifying savings opportunities based on a combination of the health systems data and also overlaying on that our research and information to help identify cost reduction opportunities and performance improvement opportunities that were actually rooted in evidence. You talk about kind of the importance of having one source of truth and obviously having visibility on everything that you guys are buying across both health systems. How important was it to actually have the evidence piece as well to support your conversations with physicians? Right.
So what in the new process and what we did, so we formally started clinical integration. We had our first meetings in February of this year. We were running different types of committees prior to that, but when we start the conversations, we always start the conversations around some sort of quality metrics, customer feedback, even a clinician safety issue or something of that nature. Then we'll talk about a supply chain category that then supports or helps that, and then we'll go through and we'll look at all of the different suppliers and the variations in the product mixes that they have, if a button's on the left side, if a button's on the top, and just truly understanding that. We get a lot of information from suppliers in Lumere. We also look at the evidence-based research. Is there one product that has a lot better outcomes than another product. Why is that? Is it the patient population, or is it really the product? So we look through all of that, and that helps to lead our conversations for sure.
I think it's important when you think of supply chain. It's actually, it's true both on the supply side, also on the drug side. You're making decisions about products that where there's a lot of information outside of the four walls of your health system, safety and issues, literature and research, et cetera. And so a lot of analytics solutions that health systems may develop internally are kind of missing that market lens to understand what's happening and what the option set is. And I think just to give the group some orientation here, historically, supply chain has tried very hard to drive out cost inflation by negotiating with vendors on price. The reality is there's a sense that there's a lot of savings that has already been captured there, but the remaining savings really requires conversations with physicians around variation and utilization. And those types of conversations really require more of an evidence-based, the evidence as the foundation of that. Our own analysis at Lumere, looking at data, this is back from 2018, but still very much rings true today. Looking at data from about 400 hospitals, 2/3 of the savings opportunity came outside of just price negotiation. So being able to have the tools to drive physician dialogue is really important. Talk to us a little bit about your use of evidence and analytics in your process and clinical integration. You talked a little bit about how when you're having conversations with physicians, you want to get a sense of, what do they like about the product? Is it a convenience issue? But you're also trying to bring to bear kind of more objective information. Kind of talk through.
Correct. So when we go forward and we speak with them, we want to understand what their demographic is and what type of patients they're using the products on, why they're using it. But then we also lead with the evidence to try to understand. So we use some internal data that helps to understand quality outcomes per physician. So we'll look at that as well so that we can understand. Lumere helps us to kind of overlap and look at some of that information so that we can fully understand how they're using it, why they're using it, the outcomes that they're having, and then have conversation as a grader, because again, we're 48 hospitals, so we have a lot of doctors that we're looking at and talking with. But the ultimate goal and the strive that we have is to make sure that we select the safest, best product for our patients to be utilized, and then for sourcing to then be able to get that at the best price. But of course, we need to talk through all of that and have an understanding with a neutral mindset as we're going into that, for sure.
Any examples kind of come to mind? Any stories from your time in the trenches where doctors really wanted something and you were actually able to use the evidence to get them to see a different approach, or they wanted something new and you were able to shed light on whether or not that would be valuable?
Yeah, so we've had several different examples. There's one recently that we've had that was more of a wound care type of product, but it was utilized in the OR, and they were adamant that it was a product that was a newer type of product out there, and we had to pull some research. It's hard on new products because there's not a lot of research out there, but when we started to look at the outcomes that were affiliated with that, actually the products that we currently had in-house had higher outcomes in a national level, but when we looked internally at our own outcomes, our outcomes were actually higher than the national level. So when we started to talk through that and we had conversations with both the requesting physician as well as the executives, we started to have this totally different conversation about patient outcomes and safety, and ultimately he decided, okay, I really don't want to use that product. I wasn't aware. So sometimes doctors have an idea that there is something wrong or their outcomes aren't as good and they want to change. Sometimes just helping them to see the full picture helps that.
Yeah. Help them understand kind of their baseline and how they compare. You talked about kind of how, yes, having evidence and data is important, but then having the right communication mechanisms is really important. And I think you guys have done a really good job of building executive leadership support for what you're doing. Talk a little bit through the mechanics of that and how do you actually feed information to those folks and what that actually does for you with physicians who are on the front line.
So when we talk about communication, that has been one of our biggest barriers, successes and failures all, all at once, I think. So obviously it's a new program, so we've had a lot of press, if you will, internally in regards to our processes and what we're working on and how we're doing it. I've been very connected with our corporate CNO and CMO as it relates to creating this process and really looking to make sure that we have a best way forward for our ministry. And so with that, there's a lot of engagement with the corporate level executives, as well as we have groups. Some people might call it a region or a market, but we call it a group. So we have group level executives as well. I work very closely with our marketing department that actually helps us get out information to everyone. And we work really hard to communicate with that. But prior to any type of decision being made, we definitely work very hard to make sure that we pull all of the data, that we're working with our key stakeholders and volume drivers to make sure that we're getting their input and we're working with their respective executives for sure.
And you mentioned to me that you're not caught in a situation where a physician who's upset goes to an executive and says, "Hey, this just happened," and I feel like my voice got a lot louder. But they're not. The executive has your back and can say, "Yeah, I understand that. This is why we made this decision."
Right. So that's part of it. So that we are constantly, if we're in there talking to someone that's in their facility or in their group, we let them know so that then they're armed with that information and data for sure. Yes.
You talked about how during the pre kind of finalization of the merger, you wanted to get your ducks in a row. Mm-hmm. Talk through kind of that process and this idea of a black box and how that worked.
Right. So as I had mentioned prior, we were not able to see specific data prior to September 1st. So we had to enlist the help of some of our trusted partners to help us kind of understand what that could look like. So Lumere did some black box work for us, and what that means is they looked at our data together as an aggregate. They were able to look at the line level, the price parity opportunities. They were able to see, oh, they're both already ordering all of these things that, and then if you do that and we benchmark it, here's some savings you could go after. At a high level, they were able to share that with us prior to the merger. But what we did is we took all of that and we looked at just the high level, and we were able to then attach that to what we knew our savings target was going to be. So we used all of that to help prepare us for that September 1 day.
Which I think is really novel. We've worked with a number of organizations that have gone through mergers, but your head of supply chain was the first to call us up and say, "Hey, I want to make sure that I have my pipeline ready to go as soon as the merger closed," and to get a sense of where is the real opportunity. So that was a really unique experience for us, but one that I think makes a lot of sense for organizations to think about as they are going through a merger. I also remember at 12:01 after the deal closed,
right.
We got a message saying, "Okay, we really want access now to the details."
Turn it on quick.
Yeah, absolutely.
And it was Labor Day weekend.
I remember.
Was crazy. Yeah.
So this idea of supply chain clinical integration is, like we talked earlier, is kind of a forward-thinking approach to thinking about things. Right. You've talked about kind of what you've done to be successful and how you've the work you did on process and governance and communication. I don't know if there's anything to add to that, but would also love to hear kind of your war stories and what hasn't worked well. I think it's always helpful to hear what you're going through and the challenges.
Yeah, I think for us, as we've been going through the merger, one of the best things we did was to get the pipeline ready. So that September 1, we were able to take some actions on some of those price parity type of things and have some more instant wins within the first couple of weeks that made us feel kind of very proud of ourselves for being able to do that type of thing. Communication has been one of those things that we've had to kind of fall down, skin our knees, stand back up, let's scrape them off type of thing and move forward. We have a very large organization, and it's a challenge to inform and keep everybody up to date. So it's something that we've had to work our way through. And on top of that, we are still in the middle of the HR portion of the merger. So there are people who were here, not here, title changes, and so keeping up with just that piece of the communication is a challenge as well. Yeah, we definitely use Lumere in a way that is our process flow. It's our process flow tool that me and my team use. It's the repository of all things within clinical integration. So we've been trying to teach and communicate that is the place. If you have a question and you're an employee, you can have access to that. So that is one of the things that we're trying to use so that people can go out and look and explore.
So there's transparency.
Yeah.
You touched on HR, and I think it's interesting. You use the merger really as an opportunity to specialize, right? So in your role, you were previously over both value analysis and contracting. Now you're really just focused on the clinical integration piece.
Correct.
You have a team of folks that report into you. Talk a little bit about your structure today and kind of where you see it going, because I think that's really interesting.
Sure. So prior to the merger, I had both the contracting and sourcing team as well as the value analysis team. Post-merger, my boss, Dan Hurry, said, I think we need to specialize. We need to really focus in on clinical integration, and then I have a counterpart that's over top of sourcing. And so what we did is we developed a plan. We have to work very closely with sourcing. Obviously, they work very close with my team. But I have a team of 5 nurses. They're clinical integration directors. They are service line focused, so they're focused on specific service lines within the ministry, and they run those committees at a corporate level. They're accountable for all of those relationships with the physicians, the practitioners, and the executives to make sure that they're in touch with everybody that works within their service lines. Yeah.
And just give us a sense of kind of how your workflow works today.
Right. So when we're identifying an opportunity, we have a lot of different ways. We've kind of spoken a little bit about the contracting. As a result of the merger, that's been a lot of our work and focus. We also have new product requests that come through, but then we also do have this piece of utilization and standardization. Really, how are we using things and how can we standardize the way that we're using things? So when those things come through, we have different inputs that are required for each project before it can be moved to phase 2 on the diagram there. So once everything is taken into account, sourcing has to put their pricing, rebate information. We get quality, infectious disease involved to get their input. And we hand it over to the committees in stage number 2. Committee is they're the only ones that make the decisions. So my team and I were neutral in the process. We own the process. We don't own the decisions. So we help implement the decisions, but we don't make them. So what we do is we talk through all of the evidence. We talk through all of the information, financial and quality. We review everything, and then ultimately the committees make the decisions. And once the decisions are made, then it goes over to our sourcing team. Sourcing solidifies those contracts. They make sure legally everything's correct. The pricing is what we've agreed to. And then once they get that done, they hand that over to our operations team to execute and implement. And once they have done that, then we can start to track the savings. The sourcing team does the savings, we track the quality. So there's 2 different lag, if you will, that we measure behind.
Interesting.
Yeah.
So clear kind of delineation of accountability and certain KPIs that each team is tracking towards.
Sure.
I think, this process seems to have worked really well for you guys. Some significant savings achieved on what's now kind of the 1-year anniversary of your merger. And I know this may be a little bit outdated, but
yeah.
Do you want to kind of share with us the latest?
So we've had some big successes. As you know, our savings is $87 million, and we're on track that we're probably closer. We're tracking that we're going to land at about 90 for not just identified, but actually implemented and across the line for this year. So we're actually just slightly ahead target. So we're not going to celebrate yet, but we're kind of celebrating a little bit. Yeah.
And just the ability to kind of deal with that pace of projects. It must have felt like.
It still does.
A lot. Yeah. Sure.
And because what we're working on is not just the easy, price parity. These are the big topics that we're working on: joint, spine, trauma, endomechanicals, all of those type of big things. Yes.
and how have you you touched a little bit about communication, but I think it's important just to touch on it again, the different levers that you use.
Yeah, so we have a monthly newsletter. I slightly mentioned that I work with the marketing department within our health system. And so I work with them in order to help get this newsletter out. And the newsletter really touches on everything that has just been approved. And then it also touches on everything that's about to launch or be implemented, so that they can just kind of keep that cadence, and this is what's coming and this is what is really just coming. And so that way we do that. We also have an executive steering committee, and monthly we meet with them, offer updates. That committee is really more for us to dialogue around goals in our pipeline, and making sure that we are fully connected and integrated with our quality team and our clinical teams to make sure that we're all working in alignment of one another. And then we have the implementation, supply chain operation implementation teams, and those teams meet monthly, and this is where that facility communication happens. So it's our supply chain operation leaders that are in the facilities that run those, but executives, the facility level executives are on those calls. Yeah.
So I'll open it up for questions before we kind of wrap up with the lessons learned. Any questions?
Right over here, I see. Oh. Okay. Oh.
And do you mind introducing yourself and your role at? Yep.
My name is Liana Pyler. I'm also in supply chain. I'm a physician, however. So our organization just moved a physician over into supply chain, which is neat. But so when you hear my questions, then you'll see how well that's going. So I mean, it's a good thing, I think. But it's fairly new for our organization.
Absolutely.
So, anyway, so when not all products can possibly rise to the level of needing a vetting and passing through committee and all of that. So I just wanted you to comment on how you bring products into that request and review process, and then, what your turnaround time looks like. And then your team, I too sort of work with the VAT teams and the and various components of our supply chain, which is very similar to what you have. But I was just wondering, for the work that you do specifically in clinical integration, how big is your team that's working on this stuff, and what kind of skill sets are really, really critical for your work? Because I'm finding for me, I desperately need data analysts, but the right type of data analyst, and that's kind of been a big hurdle for me.
So to answer your first question, so all of our projects go through Lumere. So have it be a contract, utilization, or a new product, they all go into Lumere. Then we have, internally, we have a touch point that will look at them and review them. Each request that comes through, though, we have something that we assign. It's a complexity score. So that complexity score lets us know if it's something that needs to go to committee to vote, or if it can just be brought in. With the merger, it does create a little bit of a difference, because it used to not be here, but now because we've merged, now it's in here. So we've had a little bit of some gray areas in that regard, but now we're more in alignment with everything that we're working towards. So we assign it a complexity score, and that complexity score delineates what has to have a thorough review and what doesn't. It also assigns a timeline, so that then the team members know if it's a complexity score 3, my team has 6 months from the time it's received to get it approved or declined at committee. So they also, if it's a 2, then they have 60 days. So they know that. We are transparent about that timeline. My team's held to that KPI, so they work towards that for sure. My current team that I have one project manager. She is really kind of my right-hand man. She kind of helps me oversee everything. And then I have 5 directors. They are all registered nurses. They have clinical background in their service line that they support. And then we're in the process of getting 5 managers. Those positions are preferred registered nurses, but we have quite a few supply chain healthcare professionals that can meet those needs without being an RN. So, and so that's current. As far as the data analytics, at a corporate level, we have a data analytics team. It's not just in supply chain, and that team is comprised of highly skilled analytics and data scientists that are on that team, and we have some of those team members, while they don't report to me, they are a part of the organization, and they only help supply chain and clinical integration, so they're assigned to help us. So in that regard, we're slightly blessed.
I think it's great to see how you guys are expanding your team, and I think more organizations probably look at it and say, we could invest more in supply chain if we want to kind of achieve results, and I think that's great. Just to add to kind of your question from the other, we work with about 65 health systems, and this question of what's the threshold that would warrant a kind of a real review, I would just flag two issues or two things to think about. One is anytime you add a new product, you're actually probably adding variation, right? So that's something to think about. I think sometimes you might just look at the the price of the widget and think, okay, that's my only cost, but there's actually a lot more to it. And the second thing is you might get a request for something and think, okay, we're only going to use this product a dozen times a year. I can guarantee you that no med device vendor hopes that they only stay at a dozen times a year. Their objective is to land and expand and to get into, once it's on the item master, it becomes very difficult to control usage. So just things to kind of consider. I think the thresholds kind of make sense in concept because you don't want to spend all this time, but in reality it could end up creating unintended.
To that point, so what we do is that everything comes through us. It's just what amount
of time,
what type of process from our perspective does it take, but at the end the customer sees that it goes through the process, but internally we have a different process of how much time we have to take to do all of those steps. So
Okay. Maybe we'll have a brain tease.
good idea.
All right. Yeah. Do you have someone? I'll grab the poll questions or the questions you're putting in. Please go ahead.
Hi, Lana Mechanic with ViewMed. My company actually does healthcare supply chain software and services. I'm very familiar with all those subjects. Hi, Hani.
Hey.
Thank you guys very much for speaking on the subject here, because I think it's very important that this subject is very much in the realm of healthcare analytics, because it hasn't traditionally been. But my question is the one I've struggled with over the years, and I would love to hear your point of view and your specific experience. How are those savings actually being calculated? How are they being tracked? And then tangential to this is how your executives, healthcare executives, are looking at these numbers. How are they incorporated in financial statements?
So it's a very painful it's a very painful process that is, I wish I had a better view of it, but it's very painful. So as things are approved, there is just really a spreadsheet with tabs, and it's by service line. And really what it does is it has old price, new price. Then every month they pull usage reports and bump them. And then based off of the usage of the new item, then here's the savings. And then it's all calculated out. To answer, so it's very manual and painful. There's like a week of time that there are analysts that are working on that, and there has to be some clarity. So my team has to make sure that what they're saying is the new products coming through really are the ones that were approved, et cetera. So, and so there's that piece of it. How the financial team looks at it, it's kind of twofold. So they see that number, and I have that executive steering team, and that number is shared. So every month we saved X, so that's a number. But we also talk through, so because we do have analytic support in a different type of way and capacity, we also talk through like what was the total cost per case percentage savings, what was the profit margins that we looked at. And so there's a different type of tool that we use for that, as well as just to pull just the raw numbers to say last year at this time, we spent, $100 on supplies, and this year we've only spent 80. So we kind of look at that bottom line too. So we try to create the story and tell the story with not just a fixed number. Luckily, our CFO is very open and willing to kind of look at that. So.
And that's an area we've really been focused on. How do we make that easier for folks? Because I think for too long, supply chain has only been able to share expected savings targets based on the formula of old price, new price, last year's volume. But there's actually, getting at actualized savings is more difficult. And being able to stay on top of it so that you can course correct quickly. If you talk about kind of a category where you're driving $1 million savings, you're off 10%. It's actually a meaningful impact. So we're working hard to make that easier.
Yeah.
Let's take a few of the ones that were submitted through the app.
Only if they're easy.
They're all
They're
easy.
for Hani.
The two of you are experts. We already know that now. Here, I'll hold it so you can take a look with me. I was thinking this one about, given your learnings, what would you do differently?
If you were to do redo? Yeah, that's a good question.
Is that a long, like, we're
Have
gonna
a big margarita, then step into the room. No, I'm kidding. I think in theory, I wouldn't really change anything. I think maybe my mantra is to we work really hard on the upfront so that once a decision's made on the back front, it's simple, it's easier. And so that's really my mantra. I think, again, communication is key. I think I would have gone about communicating things differently. My boss is very supportive, so I'm blessed in that regard. But we could have gone through the education throughout the internal organization a little bit differently and maybe a little bit more in advance than what we did. Yeah.
Those are really great observations. Thank you. Let's see. Did we talk enough about the type of reports or analytic tools your staff found most helpful? Not sure.
I think we kind of covered that.
Okay.
I thought that maybe this one, did your clinical integration include the ministries in Ireland? How are you thinking about having hospitals that are
Okay, so
the ocean away?
so we just acquired Ireland. So as though September 1st merger wasn't enough. So in July 1st was when we acquired the 5 facilities over in Ireland. So they're new to us. And so we're actually in that discovery phase. And Ireland does not have things like our the FDA and everything like that. So their processes are a little bit different, but they have similar mindsets. So we're working through that. And so I had mentioned that we have groups or regions. So Ireland is a 4th group or region. And so we'll be including them as far as voting membership and stuff into our stuff. Our goal is January 1 for them to be rolled into clinical integration.
I think it'll be really interesting to see not just the prices they pay for things, because we know.
Oh, it's crazy. We've seen them.
Yeah, American hospitals pay the most for
We do.
those things, right?
Yes.
But also how they're able to make do with products that are not considered cutting edge, but they have the same results.
Right. Yes,
Right.
and they do track
Yeah.
quality. Yep.
Okay. Well,
Last question.
you did a great job picking that question, so let me share this. Let's see. The other one, the thumbs up are the ones that got voted up. So someone asked about how long until the staffing issues were addressed?
Oh,
How do
okay.
you feel
Yeah.
about that one?
So our CEO was actually announced prior to the merger. Then our CNO and our COO and CMO, they were all announced shortly after September, like maybe September 10th. By the middle of September, I knew who my boss was going to be. In November, I knew what my role was going to be. And by February, my team knew. So when we were rolling out the new clinical integration, my team knew what their role was going to be. which was very fast. Typically, there are still some HR issues being worked through, so.
Wonderful, thank you. Did you see anything else that you'd like to let Hani?
Was there anybody else?
Well, I thought this question of where did the outcomes data come from? Was it internally analyzed, or were there published independent studies on it? So as you kind of think about outcomes, the combination of having...
Yeah, so the outcomes that we use to make decisions, I assume that that's probably what the question is. We use both. So if it's a product that we use internally, obviously we use our internal information, but we also always look externally as well, yes.
Great. Did you want to see if the
Yeah,
room
was there
had, anybody
Any
have
other
questions
questions?
that they didn't get into the
We can kind of summarize the key takeaways for you all before you let you go. Those were great questions. Thank you. So just to kind of summarize what I heard from the conversation today was really the importance of planning ahead to the extent that you can, and thinking about the data infrastructure that you would need, but also the governance and the communication layers that you would need to have as well. The importance of thinking about how you're going to affect physician behavior and having the right data, both having a unified view of what's going on, but also having external kind of outcomes data and perspective to be objective with the physicians and to help them.
Correct.
And I think lastly, it's this idea of mergers give you a great opportunity to change things and to drive specialization in the work that you're doing,
Yes.
but also to rethink your processes. And it sounds like you guys took advantage of that.
We did, yep.
Thanks everyone for joining,
Thank you.
and feel free to come up with any questions. Thanks.
Well, nicely said. Thank you.